Hi, everyone. Welcome to our webinar, and thank you for joining us. My name is Jeff Farmer. I'm the CEO of Diagnosis. It's my pleasure to join our speaker today, Dr. Ruth Hamilton, who will give a talk on estimating visual acuity using stepwise sweep VEP. Before I introduce Ruth, I have two quick logistical points to make. First, Ruth will present for about 30 minutes today, about half of the webinar, and then we'll leave the other half for questions and answers. And we're hoping we'll get lots of really good questions. Ruth would love to address them. So if you have any questions, even during Ruth's presentation, you can open your question pane in the GoToWebinar platform and type in your question and submit it. And then we'll organize those and go through those questions in the second half of the meeting. The pane you can open, it is located in the upper right-hand corner or near the upper right-hand corner of your screen. It's a little question mark in a box. So if you just click on that, you'll get a question pane that opens up, and then you can type your question in. So definitely do that, and we look forward to lots of good questions. So now I'd like to introduce and welcome our speaker, Dr. Ruth Hamilton. Ruth is a consultant clinical scientist specializing in clinical engineering at NHS Glasgow and an honorary associate professor with extensive clinical expertise in ophthalmology, neurology, ENT, and respiratory testing for neonates and children. She focuses primarily on physiological measurement and test development. Her research is dedicated to enhancing the quality of healthcare for patients. Ruth has authored over 60 peer-reviewed publications and has secured nearly £1 million in external grant funding. She supervises PhD and MD students and reviews for 14 academic journals, as well as several national and international grant awarding bodies. As president of the International Society for Clinical Electrophysiology of Vision, ICEV, Ruth is leading strategic initiatives, including expanding the Society's test portfolio to align with pharmaceutical trial entry and endpoints, and establishing an international task force to develop a global open access reference database. Ruth, welcome, and thank you for joining us today.
It's a pleasure. Thank you for asking me.
You're welcome. I'd like to start off by asking you a question, and it is, what motivated your work on estimating visual acuity using VEP techniques back in the 1990s?
Yeah, it's a good question. In fact, I wasn't involved in the start. I got involved in this a few years down the line, and Mike Bradnam, who some of you might know, was the instigator of this work. But back in those days, we were frequently testing babies and children in the visual electrophysiology clinics, and the clinicians really wanted to understand what sort of level of visual acuity the child had. And the only method we had at our disposal was using transient VEPs to lots of different check sizes. Now, with transient VEPs, obviously each one has to be reproduced. Sometimes the VEP is really small, so you need extensive averaging, or the EEG is really big. And often the children had different clinical difficulties, morbidities, learning problems, and so on. So their fixation and their attention could be really erratic. So it's just really challenging and took a long time to get down to, well, what's the smallest check size we can still see a VEP to? So we also knew, of course, of the sweep VEP techniques, which have been around since the 1960s, and Russell Harter, Carol White, David Reagan's a long and rich history of using VEPs to estimate thresholds. And we knew, of course, of Tony Norsha's commercial system called the Power Diva. These are all based on a sweep, so moving through different sets of check sizes. Actually, quite quickly, they stop being a true sweep, where there's a gradual change in check size, and actually became a stepwise sweep. But there was still a drawback there from the perspective of how we wanted to test our patients, because they were generally set up so you watched a fixed number of check sizes and you watched each one for a fixed number of times, or you swept through them a fixed number of times. And we knew that this would mean expecting our patients to look at a stimulus which for a lot of the time was too small for them to perceive. And So it just made it more challenging. So we thought maybe, or Michael thought maybe we could do this a bit better. And we borrowed from psychophysical testing and from auditory electrophysiology processes to make this what we called our STEP VEP system. And then we used that in our clinic for 20 years or so until, as you know, Jeff, as of a year or so ago, Diagnosis got it implemented on your Espion system. So that was the background.
Excellent. Thank you.
So we could just move on now if that's okay. I think we're going to start the presentation with a short video, and then I've got some slides. So if you
Sounds
can
great.
put the video up.
I'm Ruth Hamilton, a clinical scientist working at the Royal Hospital for Children in Glasgow in the UK. And in this video, you'll see me testing my colleague, Bruce Hudson, who's acting as a patient for demonstration purposes. We're going to show you how the Diagnosis STEP VEP system works, a system developed by myself and colleagues here at the Children's Hospital. So you can see that Bruce has 3 electrodes across his occiput, a frontal reference electrode, and a virtual ground on his left mastoid. That gives us 3 VEP channels, and we create a 4th Laplacian channel by using the average voltage at O1 and O2 as a reference for OZ. Laplacian channels are good for small signal conditions. The stimulus is a high contrast checkerboard, reversing about 8 times per second. So these are steady state VEPs, not transient VEPs. The STEP VEP software is analysing the EEG in real time. If it finds a significant VEP, it responds by stepping down to a smaller check size, and if it fails to find a VEP, it responds by stepping up to a bigger check size. And we use a 4 down, 2 up, 1 down staircase. I have very little to do here because the process is fully automated and Bruce is behaving as a very compliant patient. But of course, in a real patient situation, I would be constantly observing the patient's fixation and pausing the data analysis for every instant the patient is not looking at the stimulus. In paediatrics, one tester is usually working hard to maintain the child's interest in the stimulus screen, while another pauses whenever fixation is lost. That, of course, is no different to any other VEP recording. Now let's have a look at a couple of examples where we can watch the operator screen in detail, and we're also showing the stimulus screen in the lower right corner, so you can see how the real-time analysis governs the stimulus check size. Now let's orientate ourselves here. We have 4 VEP channels, OZ, O1 and O2, each reference to FZ, and in the bottom right our Laplacian channel. On the right-hand side of the screen, we have our list of available check sizes, from very big checks up here at the top to very small checks at the bottom. So let's start our recording now. You can see the 4 channels of ongoing EEG data. An inset in each of these time-based windows is a frequency-based plot. We're looking for a significant VEP at the stimulation frequency. A VEP was found there, and you can see that the stimulus has changed to a smaller check size, and in the results table we have a green detection against that last check size, and we've dropped 4 steps, and we're now trying the check sizes indicated by the blue band. If the VEP is quite big and fixation is good, the VEP can be detected in 1 or 2 seconds, so it can be pretty quick. The detection statistics have been designed to keep the overall false positive rate at about 5%. We flag check sizes in orange where the VEP was close to being statistically significant, but they are nonetheless treated as a no, as a red check size by the algorithm. So the test continues, stepping down in 4 here. And for each check size, we have a maximum of 11 epochs before the algorithm will give up and assume that no VEP is present. This is a configurable option, and it depends on the choice of epoch duration. Here, we're demonstrating epochs which are 2 seconds in duration and use a maximum of 11 epochs per check size. There we have an amber result, same as a red as far as the algorithm is concerned, i.e. no VEP is present, but with a close to statistically significant result, as we already talked about. We will therefore jump up 2 steps. No VEP detected there, hence red. So the test is complete now. Looking at the table on the right-hand panel, you can see that in a downward direction we have green, green, red results for consecutive check sizes, and that is how a threshold is defined. This is analogous to a similar threshold finding technique used in auditory electrophysiology. And let's take a look at how this test would be reported. Check sizes are big on the left through to small on the right-hand side of this central chart, and the grey vertical zone represents normal for age from reference data. Green dots indicate a VEP was detected, red means not detected, and amber means only approach statistical detection level. And the numerical values here give the threshold and precision estimate in cycles per degree, as well as aged match reference limits. And there is also a conversion derived empirically for what the corresponding chart acuity might be. Let's watch another example. A few things to notice here. The process always begins with large checks because we designed the system to maximise the amount of time a child was looking at a stimulus which they could see. Notice also the low noise level on the Laplacian channel. Those close reference electrodes are very effective at cancelling noise but preserve a lot of the signal. So often the Laplacian has better signal to noise ratio than the real channels. We're performing 2 different analyses on each channel. Firstly, seeking a critical signal to noise ratio, and secondly, undertaking circular t-squared tests which look for vector clusters which exclude the origin. No VEP was detected there, so it's 2 steps back up the staircase. Remember, we're seeking green, green, red for consecutive check sizes getting smaller. That's now achieved, so the test is finished. That one took just 90 seconds total recording time because not too many check sizes were needed. And the report for that test shows the threshold here in cycles per degree, which is substantially poorer than is normal for age. Expressing these thresholds in cycles per degree relative to aged match reference data is really all that's needed. There is also the option for the far more variable interpretation as a related chart-based acuity.
Great. Okay, I hope that explains a bit. I should probably explain. Bruce is not 2. He's a grown adult. So we're going to move on now. I'll just put my camera off so you can see all of the slides. So we're going to move on now and go over some of the theory and practice behind VEP estimation of visual acuity. And this, let me just get control of the slides. Okay, a little bit lag. So this review paper, which I think the organisers have put in your materials, was written in 2021 by the people here and has really all the information that you probably need and lots of detail. Published open access from Documenta Ophthalmologica. Now, the single most important message, really, of this talk is to note that a VEP spatial frequency threshold, that is the stimulus element size at which the VEP is no bigger than noise, is not the same as visual acuity measured behaviourally using charts. And there are several reasons for this. So they are listed down the centre of this table, and you can see how they differ. So the amount of retinal area used for either task is different for VEP than for acuity, chart acuity measurements. Similarly, with fixation duration that's required. Also, different brain areas are responsible for generating whatever response is used to indicate a seen stimulus. The nature of the stimulus itself differs for either task. And also, the way a threshold is defined differs for either task. So because of all these differences, a VEP threshold and a chart acuity may not always be in close agreement. However, the agreement is sufficiently consistent and close that, as long as there is suitable regard for disorders likely to produce exceptions, a VEP threshold is an excellent complementary tool for clinical assessment of acuity, and indeed might be the only option if behavioural testing is not possible or is not reliable. Now, over the last 40 years or so, many variations of sweep VEP, step VEP have been implemented. But in general, it follows the process follows this cycle round here. There's some combination of stimuluses, lots of variations that are used, being sequenced in one of very many ways, which elicit steady state VEPs. These VEPs are captured using the same occipital electrodes as is used for ICEF standard VEPs. And then the EEG that's captured that way gets analysed offline in the frequency domain typically, and with objective statistics used to determine whether or not a VEP was evoked. And then the threshold is defined either as the smallest stimulus evoking a VEP or by extrapolation to some noise floor. And there are other methods. For example, the Bach, the Freiberg lab version is very well described and validated, and I think is already implemented in a version on the Espion system. Now, I'm using the term steady state VEP, and it is possible that some are not familiar, so just let's recap briefly on this. Let's think first of all about the ICEF standard transient VEP shown here at the top. We elicit that with a stimulus that typically reverses maybe once or twice per second. Now, this is a transient response, by which we mean that the relevant brain mechanisms are able to return to their resting state before the next stimulus occurs, i.e. the next pattern reversal. Now, by increasing the reversal rate, the waveform that gets evoked can look quite like a sinusoidal wave shown around about here. And that means that this waveform can be really simply represented in the frequency domain by widely spaced harmonics, which remain relatively constant in amplitude and phase. That's a steady state response. Now, all these VEPs shown here have been heavily averaged in the time domain so that the signal shape is actually evident. But of course, in real life, you're looking at these buried inside large EEGs. One of the advantages of the steady state VEP is that being nearly sinusoidal and knowing exactly the frequency that was used to evoke the sinusoid allows these steady state VEPs to be very objectively detected in the EEG and also analysed. So that gives us these two advantages. Steady state VEPs are both fast and they're objective. However, there's a loss of information. What we no longer have is this wave shape here, which we're all used to looking at, and we've lost the richness of information carried, for example, by the peak times and by the wave shape itself in the transient VEPs. So it's a trade-off. Now, going back to the system which we developed, we had noticed that existing systems typically used a fixed set of stimuli, all presented for a fixed amount of time, and all the analyses were conducted later offline. And as I noted before, this using a fixed number of stimuli for a fixed number of time meant children often had to be persuaded to spend some portion of the test watching a stimulus which they couldn't see. It was below their perceptual threshold. So this was where Michael Bradnam's idea came in, to make a smart system. And the smart simple system, quite simple in concept, used real-time analysis of the EEG to govern the size of the next stimulus presented. And by using that idea, we closed the loop. So we start by showing the child a nice big pattern to begin with. We analyse their EEG in real time. We perform objective statistics on it to determine whether or not there is a VEP in response to that stimulus. And if the answer is yes, we show a smaller check size. If the answer is no, we show a larger check size than just watched. And the whole process can be fully automated. Now, as with all tests, of course, a key part of understanding the clinical significance of the result is knowing what is normal. And this is explored in a lot of detail in the review paper, which we mentioned earlier, which is available to you. In this graph here, which is taken from the review paper, we've collated the findings of thresholds in typically developing infants, children, and adults across all ages. And age is shown on the it's shown on the x-axis on a logarithmic scale, while VEP thresholds in cycles per degree, again logarithmically, is shown on the y-axis. And each of the different coloured spatter of dots represents a different study. So generally the test types used and the variations exist across there, but you can see quite a good consensus on the sort of thresholds that are obtained. And it's quite clear that the spatial frequency threshold matures rapidly over the first year of life. It's adult-like, by which we mean about 15 to 40 cycles per degree typically, by around about preschool, start of school age. And it's worth pointing out, I've indicated here in the red boxes, the ICEF standard check widths. So this is the large check and this is the small check. So if we consider, for example, even a 6-month-old child, a 6-month-old child's spatial frequency thresholds are, what are they, maybe about 7 to 15 cycles per degree, something like this. So already much, much smaller than even the ICEF standard small check width. Okay, just going to wrap up this part of the presentation with some conclusions and some warnings. The most important is that behavioural measures of acuity are the gold standard, and VEP thresholds are not a one-to-one substitute for behavioural acuities. For that reason, VEP acuities should be reserved for only those conditions and those patients where it's most accurate and precise. That, in our clinic, tends to be preverbal children, children with learning disabilities or motor impairments that preclude them being able to reliably perform behavioural acuity testing. And the other group is children with suspected non-organic visual acuity loss. Interpretation of the VEP threshold is done by simply expressing the individual's threshold in cycles per degree and presenting that relative to age-stratified reference data. Some important points, and this is really, really important. It is not appropriate to convert the VEP stimulus geometry in cycles per degree or whatever into logmar or Snellen or any other behavioural acuity units and to ascribe that visual acuity to the patient. Doing so risks being out by quite a long way. For example, for adults, this inappropriate conversion would underestimate an adult's likely chart acuity by about 0.3 logmar, by about an octave. And even worse, if you undertook this in an infant, for example, you could be overestimating an infant's acuity by about a log unit, which could, of course, have disastrous consequences for their management. If you feel obliged to choose to approximate the threshold in the language of behavioural acuity, then an offset has to be used. And the offset has to be particular to the test, and it has to be particular to the age of the patient. And it's calculated empirically. The implementation in the SVN system does incorporate these offsets. And then finally, and again, this is really important, the test should never be used in isolation, but rather it complements the findings of other electrodiagnostic tests, as well as the clinical and imaging findings for the child. Thank you very much for listening. I really love to hear your comments and answer any questions that you have, and particular acknowledgement to all the work that Mike Bradnam has done on this over the years. I think Mike is here. Michael's on the webinar, so thanks to him.
Hi, Ruth. Thank you very much for the excellent presentation and the video that you and your team put together.
No problem.
We have now about a half an hour for questions and answers. We have a few questions that have come in already, but just a couple. So if you do have questions or topics that you'd like Dr. Hamilton to address, please let us know. Type those into the chat bar. Some of those our team will respond directly to you on. Some of them will tee up for Ruth as we go through the next half hour. So we've got a few to start. And Ruth, maybe a good place to start actually is if I could go back to the last couple of points that you made on your last chart on dealing with the information that you have from these methods that give you information in terms of cycles per degree and then estimated chart acuity and the warnings and cautions that you just talked about. Could you bring those thoughts back into how the method addresses that and what information is being used kind of behind the scenes in the method that you developed and then is now in the SBN software, and how that method helps address some of those challenges that you mentioned?
Yeah, sure. So, I mean, I started off by saying that, you know, a VEP threshold is not the same as behavioural acuity for all the reasons listed. And, you know, for that reason, it would actually be really surprising if we ended up with the same number, you know, if you got an adult to read down a chart and then, or even just say whether or not they could perceive a black and white checkerboard, and then also simultaneously look to see if there was a VEP there. They're measuring different things. And, you know, if you think about what's going on, if you imagine a typically developing adult where they tend to get better acuities from a chart than they do from VEPs, well, their brain's got better access to what's going on in their visual cortex so that they can go, you know, it's an E or it's a duck or whatever the task is, than our electrodes have sitting several millimeters away through a skull. So it's not surprising that the two don't match up. So for that reason, when you get your cycles per degree from VEP, that's an absolute valid measure of a threshold, but it's valid for what the VEP tells you, not what behaviour tells you. And in order to bridge between those two, and I know that sometimes clinicians are very keen, they just say, well, what's the acuity? Just tell me the acuity from a VEP. And I understand that desire, it makes perfect sense, but it's not as simple as that. And the way you get around it is you have to test people. So you have to take a bunch of healthy adults and you have to check what their acuities are the two different ways, and this gives you the value for that offset. And then it's even more complicated in kids, of course, as everything is. When you need to test kids, then you need to do the same again. You need to measure their VEP acuity, and you simultaneously need to measure in the same kids what their behavioural acuities are. And in infants, especially, it's very marked. We find exactly the opposite. So where infants will have a preferential looking acuity of maybe about 1 logmar or something like this, which is typical and normal for a small infant, your VEP number looks a lot better. The reasons for that are not entirely clear, but there's some nicely explained hypotheses from other workers that are summarised in the review paper. So the consequence of this is the number that the VEP acuity software spits out is only pertinent to VEPs. And if you want to talk about chart acuity, correlating it with chart acuity, then it's a much more complicated step, and relies on what we know empirically from testing subjects in using both techniques.
And if I remember correctly, I don't remember the exact number, but it was a few hundred subjects that have been tested from the review paper that you talked about and then from your clinic that were used to try and create this bridge.
Yeah, absolutely. So we have our own validation values from our lab, which was actually all done offline on older versions of the software, and at the same time, we had all those lovely kids came in and let us measure their transient VEPs as well, which is where our reference data base for transient VEP comes from too. But we also collated that for the purposes of the ESPN implementation with robust and similar studies in the literature.
Excellent. Thank you. The next question is, can you take us through one or maybe two cases quickly, clinically, where you use this method? What type of patient, what sort of question you're trying to answer, how the test method helps you clinically?
Yeah, so a really good example. So one of the clinics that we run about once a month or so in the Children's Hospital, we tend to see really complicated children. So these are children who've maybe got congenital or acquired brain injuries, maybe been born extremely premature, or have other difficulties. Perhaps they're non-verbal, they may be using a chair, they may be unable to feed themselves, and so on. And sometimes they might have difficulties, for example, with controlling or electing correctly how their eye movements. So typically these kids would come into the clinic and our specialist orthoptists would have a shot at measuring their acuity, maybe with preferential looking or whatever other appropriate techniques they might try and use. And sometimes that's quite successful and they'll get a fairly crisp threshold. Sometimes they don't get anything. They can't get the kid to look to the left or to the right, which is what is usually required in a preferential looking task. So in the same clinic, these kids will also come to us and we will, amongst all the other tests that we'll do on them, we will do their step VEP as well. And there's some advantages. So for example, if they're fixing on the screen, so if they're aligned so that their gaze falls onto the stimulus screen, they don't need to make saccades in order for us to understand what's more appealing for them to look at. It gives you a second measure of their acuity. That's really useful to the clinicians in the clinic. Sometimes the two measures disagree, and sometimes the two measures agree closely, and sometimes only one of us gets something that's usable. So that's the first use case, and we use that quite regularly. The other use case, which I think you'll all be familiar with, is the maybe a teenage person who presents complaining of being unable to see clearly, sometimes both eyes, sometimes just one of their eyes. And the clinicians have found no structural reason for a problem with their vision, and they suspect that there's maybe something functional going on, that this is maybe a child who's reacting to some kind of trauma or some other upset in their lives and experiencing, that's most often the case with children, experiencing problematic visual acuity as a result. And that's really useful to do because usually these are older children who are really happy to comply with testing, and we are able to very quickly establish or not that the eye or eyes that are supposed to be not seeing clearly for them are actually being served by a visual cortex that can resolve right down to normal healthy thresholds for their age. So this is an extra piece of information which is particularly useful to ophthalmologists when they're then managing the children, is they're reassured that they're not missing an organic problem. And actually those cases are absolutely great examples of where the step VEP is just one thing that you do. You know, you have to do everything else with these children. You have to make sure that they're appropriately refracted, that their pattern ERGs look normal, that their full field ERGs look normal, that you've got, yes, you've got your step VEP threshold, but if we then do supra-threshold check sizes to ICEF standard checks, for example, that you've got normal amplitude and timing of the P100 of those. So collectively, all of that gives some reassuring news to the news to the ophthalmologist to use in conjunction with imaging and all the rest of investigations for the management of the child.
Excellent. Thank you, Ruth. We have a lot of questions now that have come in,
Okay.
so we'll rapid fire a few of them. Here's a good one just to talk about the method. So how repeatable? How would you describe, and can you summarize some of the work that's been done to quantify the repeatability of the test? The specific question is, if I test someone on today and then I bring them back in next week, how repeatable should I expect this type of a method to be?
It's a great question. I don't actually know the number. This is something that Jeff, you and I have talked about needing to work on so that we can have that out there. In experience, you get a bit of variability, maybe a check size either side when you repeat test somebody. So it's pretty robust, and at some point we should have a number out there for people to use.
A good one for our research project. Next question is, we've got a couple of questions just in terms of, can you test with this type of patient? So let me ask you a couple of those. So the question is, can you study children with seizure disorders or with a seizure disorder?
Yeah, and we frequently do. I guess the issue there is big EEG is often what you see. But again, this is where the steady state VEP has some advantage, because most of the EEG energy sits at frequencies just a little below where we're looking, or certainly not peaking at the frequencies that we're looking at. So it's maybe a bit easier to pick out a steady state VEP in that background EEG than to try and average it out with a transient stimulus, especially given the time that can take with transient recording. So yes, you can, but exactly in the same way that it will take longer to do a transient VEP in a subject with big EEG, so it will take longer to detect steady state VEPs in that patient.
Okay, thank you. Another similar one. So the question is it possible to perform this in children with global development delay and or in a sedated state?
First one first, yes, very much so. That's the majority of the patient group. We never do VEPs under sedation. Sedation has a marked effect on the VEP. And if it's obliterated, you don't know if it's due to the sedation or due to the child. So I don't know the answer to that because I've never done it.
Okay, yep. Glad we addressed that. A couple related to quote unquote fixation. So maybe you can just, I'll bring a couple of these together. One question is how long does the patient have to fixate, the baby or the subject? And another version of the question is how can we ensure that the baby looks at the center of the LCD monitor during the test? So I think that's a great topic to talk about practically.
Yeah, yep. It completely is. So I'm just going to reiterate such an important point. So you have to monitor fixation like a hawk. And the very second you see a person's gaze deviate off the stimulus, you pause. Now, that's no different to doing any electrophysiology test, but I'm just emphasizing that because the last thing you want is the EEG you're analyzing to be diluted with EEG in which there is no VEP. And that's what happens if you continue to record when the patient isn't looking at the stimulus. So we have a pause resume button. Somebody's watching them like a hawk. You are only acquiring data when the eyes are on the screen. How long does it take? Well, I think you saw in the video where Bruce was being the perfect patient. The patient looks, you'll get to a threshold in somewhere between 1.5 minutes and 2 minutes typically. If you need to pause because the patient's fixation is intermittent, it will take longer because you need to add in all that pause time. If you want to make a patient look at the stimulus screen, you've just got to be prepared to be a bit silly. So we tend to use bright marker pens, so we're drawing shapes, we are singing, you can dangle keys, anything that doesn't obstruct much of the stimulus. You dangle keys, you make things dance and laugh. I know some people have lovely setups where there's intermittent cartoons that you can show. We don't use that in our setup, but I know that works really well. yeah, you've just basically got to be prepared to work your socks off to keep the kid interested in looking at the screen. That's the deal. And there's no easy way around that.
I'll just quickly mention, you noted that there is a pause button box that I don't know that we had in the video because you were running with an adult, but that's just handheld, so you can operate it with one thumb, as Ruth mentioned.
Yeah, and the advantage of that, of course, would be that you could theoretically operate single-handedly. So
Right.
you're both entertaining a kid and pausing acquisition and so on. I recommend that very, very highly.
And this, I'm not sure if we've mentioned to you, but we have a starter toy that we're shipping now with the test as well. So you have something to do with the other hand as you're attracting attention of the child in the ways that you discussed. So great point. So another question here, a little bit along the same lines, somewhat anyways. Can you discuss the difference between monocular and binocular testing? Which do you do? If you do both, do you do them in different situations?
Yeah, great question. It's really important. So they do differ. So the literature tells us and experience that if you are testing monocularly for steady state VEPs, monocularly, the amplitudes of the magnitude of the responses tend to be anything from the same size as binocularly to half the size. That's typical. So that might mean that monocular recording takes a little bit longer. Which one you do depends on the clinical question. If you're being asked to make estimates about everyday behaviour of a child that's got multiple difficulties, both eyes open testing is the relevant question that needs answered. If you're being asked to assess a 13-year-old girl who says she can't see anything out her right eye, you're going to test her right eye and her left eye separately. So it's very much governed by the clinical question.
Very good. Let's see. Actually, maybe another thing we should just touch on quickly is the number of electrodes used in the test.
Yeah.
From the video, we showed a 3 active electrode setup. Can you touch on that versus the 1 active electrode setup, and again, where where each of the different setups are used in the method?
Yeah, so it's a good question. So this was work that was largely led by Alison Mackay when she was with us doing her PhD. And what she not only looked at the optimal positioning for the lateral electrodes, but she also checked what age having a Laplacian channel, which uses those lateral electrodes, became effective. And actually what we found was that kids under the age of 3, there's no real benefit from the Laplacian channel. It didn't perform any better than the single midline channel, OZ, reference to FZ. So what the conclusion we get to is for children over 3, you will see a benefit in terms of faster test results if you use 3 electrodes to create your Laplacian channel. Of course, a lot of these kids, you're going to maybe be putting the 3 electrodes anyway on to do their VEPs. That's quite standard in some labs. No longer part of the ICEF standard, but there's plans afoot to develop extended protocols to describe good use of that. And that's good for lots of other things, as well as faster step VEP thresholds.
Thank you. Another question is, I'll summarize it, is that these types of techniques, VEP and electrophysiology techniques, are used in large institutions in specialty centers such as yourself in pediatric and adult clinics. What guidance would you give to smaller clinics who perhaps have never done electrophysiology techniques and maybe are interested in, could this help in their clinical practice without any background in, say, electrophysiology or VEP specifically?
Yeah, so that's easy. Join ICEF. Of course, I would say that. Of course, I would say that. Although it's not a flippant point, ICEF is very welcoming of newcomers, and we have a comprehensive educational program that can help people who are new to the field to get started. It's maybe not something just to jump into in isolation, but I would note that The manufacturers associated with visual electrophysiology generally provide very, very good support as well. You would probably need both, I think, to get started. And the other thing is that our membership are extremely generous with their expertise and their time. And very frequently in the past, where centres are starting up with a new technique or starting up from fresh, it's been possible to connect them with ICEF members with the right skill set to help them get trained, even visiting them and helping them getting trained and getting off the ground with a new service. So if that question has come from somebody and anything I've said interests them, please contact me, and I would really like to help you get on board with using visual electrophysiology.
We can put the ICEV website URL in the chat bar as well for those who don't know it, so that they can check out the ICEV website. Good idea. We've got 2 or 3 questions actually in an area that you and I haven't spoken about, so the answer may be no. But they're related to animal testing, either large mammal, non-human primate, rodent testing. If I bring all of those together, again, since I've never asked you, I'm not sure. Do you know if this method specifically has been used in animal testing?
Yeah, it has. So I guess just know about this from reading in the field over the years. In fact, I was just trying to brush up on my knowledge of the field yesterday ahead of this webinar. And I saw a really nice paper which was in mice where they were using steady state VEP as their outcome measure, and also using some machine learning to support the analysis of it, which was really interesting. Actually, Michael Bach's lab have also done that for human steady state VEPs. So yeah, so this is most definitely a technique. If you can do a transient VEP on an animal, then you're probably going to be able to do a steady state VEP on an animal if you've got the right kit.
Yep. And I'll just quickly add, we can follow up on those questions for people who have asked. They get in a little bit to kind of commercially what is capable to do on our system. But we have done these types of techniques using, you quickly mentioned, we also offer the method that Michael Bach has developed. We call it the Freiburg stepwise sweep VEP method on our systems. So we've used that. The Glasgow method is new, which is why we're having the webinar, to diagnosis systems. And I think either one of them would give us a tool for any of the types of animals, larger mammals down to rodents, to help people interested in using this type of method in their research. So if you're interested, feel free to let us know and we can do some follow-up on that. Another question, you touched on this, but let's see if there's a little bit more you'd like to add. So are there any clinical conditions that would preclude using the method? Back to working with children and pediatric children. Can you maybe just spend another couple of minutes on places where you would maybe love to use it, but you'd say, nope, we're not going to use it here?
Yeah, so it goes back to my very first point, doesn't it? That if you need to test you want to know someone's acuity, your gold standard is a behavioural method, whether that's chart, preferential looking, depends what's suitable for their age. And if you can do that, then what really is the reason for doing a step VEP? So that's the first thing. Then you get into the difficult position where maybe it's unreliable to try and do behavioural testing on somebody. The review paper is really useful here. So the review paper, I've got it here. So it actually goes through condition by condition and pulls out everything we know from the literature about where there is good agreement. And by that, I mean a systematic agreement. I don't mind about the offset here. It's just whether the agreement is systematic across all acuities, good to poor. And some surprising findings. We find really, really variable results in optic nerve disease. And also we see the same in macular disease. Potentially this is just because of the extent of the macula involved. Obviously, what your VP electrode picks up at OZ is predominantly macular. So it can be quite grossly affected if there's a lot of macula affected, but if some perimacula is spared, it might not be. So that might explain why you get such variable results. But most people with macular disease can perform an acuity test, so is it really helpful to go down the VEP route? The other one that I would pick out, because this is a subject of such a long and extensive literature, is amblyopia. So we know, and known for a long time, that VEPs are really relatively insensitive to the sort of scrambling blur that children with amblyopia have, that can make performing letter chart acuities so challenging, whereas the VEPs are left relatively unscathed. So the correlation across a large range of acuities is really poor. And for that reason, we have concluded in our paper that the steady state VEP, step VEP estimation of acuity is not reliable or useful in children with amblyopia. And interestingly, we see really similar outcomes in children with cerebral visual impairment. And I know it's often been posed that actually amblyopia is an acquired cerebral visual impairment of itself. And maybe that's why we see such a close overlap between the two.
Excellent, thank you. Another question is, again, as you noted during your talk, as you were discussing some of the other methods, many other methods that different labs have created over the last 3-4 decades. I think you quickly mentioned that there was at least one commercial system that was quite common here, actually, in the United States. I'm not sure if it was as common in Europe and the UK. But the Norsha Power Diva system. So we have a question. Again, I'm not sure if you have thoughts on this or not, but I think it's a good one because there were a lot of Power Diva systems that people used. So the question is, do you have any experience with the stepwise method that we've been discussing compared to the Norsha Power Diva system?
I don't. I did speak with Tony Norsha when we were writing this review paper, and then subsequently. I think his Power Diva is out of production. There probably are some units still sitting around being used somewhere. But to the best of our knowledge, and it was a pretty thorough review, we have never seen side-by-side comparison of the two. But maybe now both the Freiburg and the Glasgow techniques are commercially available, as is maybe still somewhere the Power Diva. Somebody will be able to do a comparison and let us know the answer.
I was thinking that would tee up to, you're right, and it's one of our goals. We don't have a program committed with the site yet, but we have done some benchmarking work at Boston Children's Hospital here in the US, for example, of the Glasgow method that we've been discussing versus the Norsha system, and no conclusions yet. That's been an ongoing study. But I'm hoping in the next year we can do a more formal study of the Freiburg method, the Glasgow method, and the Norsha system. I do think that would be helpful to a lot of people, just given the prevalence of the Norsha system over the last 20 years.
I agree. And it'd be so interesting to find, because they're all sort of looking at the same thing, but they're looking at it in a slightly different way. And some would be good for some populations and some would be good for others. So I don't think any of these systems are in competition with one another. I think they probably offer you complementary takes on the same problem. So it'd be great to see some comparisons being published.
Excellent. We have just a couple minutes left before we close up, and we have more questions than we'll have time for. And we'll certainly follow up with everybody's questions if we don't have a chance to address them. But let me see, I've got one or two a little bit more technical questions. Let's just toss those out. So one is the question is there any advantage to using the checkerboard stimulus instead of gratings? Or if you want to just turn that into a summary of the difference.
Yeah, so the VEPs they elicit are all pretty much the same. We stuck with checkerboards because that was what was familiar from ISF standards, and they were easily generated even on old CRTs. Don't know why I say old, we still use a CRT, but anyway, that's changing. The only difference that you get with checkerboards compared to a different stimulus is you tend to get a lot of notchiness in the response, which meaning at sort of medium-sized checkerboards, the amplitude drops off a bit. And so you have to take care that you don't fall into the notch and think you're at the threshold and push on through smaller check sizes. But we think it's pretty robust compared to other stimuli.
Thank you. Another slightly technical question, is the establishment of the threshold detection based upon the raw signal, or is it based upon signal to noise ratio? Again, you touched on this, but maybe if you want to add a bit to that.
So I guess it's kind of both. So the signal is processed, and we process it in two different ways. We take our little 1 or 2 second chunks, and we calculate for each chunk what the phase and the magnitude is of any signal, and we look for those phases clustering in all the sequential chunks as they come in. That's one analysis method. The minute the tips of those vectors exclude the origin, we can declare a VEP. Simultaneously, we are doing time domain averaging of the DFT output, and we're looking for that spike, the signal at the frequency, compared with the magnitude of the immediately neighbouring frequency bins. And we're looking for a criterion signal to noise ratio. So those both happen simultaneously. And we do corrections for the fact that we're doing 8 different calculations on the same data.
Excellent, thank you. Last question then. Let's bring it back to a really practical challenge that we see working with customers all over the world who are pediatric doctors. And the question is, if you know that the patient has a limited attention span, basically, again, you've talked about it, but I think it's a good place to end. Any other tips and tricks you use? Do you sometimes do this or that? Any other guidance for what is a big challenge in working with young children, sometimes young children with mental disabilities as well, that you would pass along to the group?
Yeah, so it is challenging sometimes. I think important things are make sure the parents are on side. They've got to understand what's happening, what you're going to do, why you need to do it, and what happens afterwards. You know, how are the results going to them? Think about what the most important single test is that you need the results to, and start with that, and then work your way down through the priority from there on, and be prepared to bring them back another time. To be honest, that's not so often needed. I think you've just got to, you know, in a pediatric clinic, you might spend a lot of time on your knees on the floor and singing, and sometimes holding the child yourself. And yeah, adaptability, I think, is the key.
What we've tried to do in the method, and Ruth and her team showed it well in the video, I think, is automate as much as we could the process of some of the things that could be done manually, but we thought, well, let's do all of that in software, because the job is hard, as you just described, and trying to keep things as simple as possible in terms of operating the system. So we have I'll kind of take that point and then work towards our concluding remarks here to wrap up the webinar. We have the system implemented, the method implemented in our systems. It's available. It's new though, so we've done a lot of testing over the last year on the method. We're making it available commercially to customers in about 2 months, generally worldwide. And we look forward to feedback as people start using it. One of Ruth's questions, she and I hadn't spoken for a couple of weeks, but when we got together early this week, one of Ruth's questions was, what sort of feedback do we have from users? And I said, well, none in the last couple of months, but I think we will. And so we're very much ourselves at Diagnosis and Ruth interested in people's feedback as they use the Glasgow method and the Freiburg method on diagnosis systems. If there's ways that we can make it even better and try and make your life a little bit easier as you're trying to test, in a lot of cases, really difficult subjects, let us know. Both Ruth and we are happy to continue to make improvements. So with that said, I've got a couple of final points here to wrap up. First of all, just note that for the questions that we haven't been able to address in the live session, we'll definitely get back to you. Ruth will help us with those. Thank you for all of the questions. We had more than we could address in the half hour. The video recording of the webinar session will also be made available. So if you have colleagues that would be interested in this, you can feel free to share that with them. I'd like to thank Ruth. Ruth has put a tremendous amount of time, and her team, into preparing the video, preparing for the talk today, and giving a fantastic webinar session. So thank you, Ruth, for joining us and all the work that went into this behind the scenes by you and your team.
It's a pleasure.
So a couple of final things then. For those of you interested to learn more about the Glasgow stepwise sweep VEP test systems, In addition to what I just mentioned, you can also go to the Diagnosis website. In the Contact Us section of our website, we list all of the sales and support people. Feel free to email them. They can send you more information on the test, papers, brochures, things like that. We're more than happy to help. So feel free to contact us. Also on the website, there's a newsletter, Diagnosis newsletter, that you can sign up to. That goes out typically every 3 months or so. We try and work with ICEV in a way of educating people and kind of keeping people up to date on what's going on in our field in the newsletter. So it's a good one just generally to be on. If you're interested, you can sign up to that through our website. And then finally, for those of you mainly in the US, but perhaps in other parts of the world, if you plan to attend the 50th annual meeting of the American Association of Pediatric Ophthalmology and Strabismus, APOS, in Salt Lake City next week, we'll have a booth, so feel free to stop by and say hi. And with that, I'll close out the webinar session. Thank you, everyone, for joining us. We really appreciate that you were able to, and have a great day. Bye-bye.